topic for discussion now is few of special infections we'll deal with, and we'll talk about actinomycosis and leprosy in this presentation. So coming to actinomycosis first, as we all know, actinomycosis is a chronic suppurative again granulomatous infection. It is usually caused by actinomycosis, mycos israeli. Okay, this actinomycosis is usually sometimes, even in the normal people also we can isolate it, especially in the oropharyngeal region, especially in the crypts of the tonsils, oral mucosa, some amount of dental cavities. In the pharynx also, this actinomycosis israeli is usually a normal commensal. However, because of some, in few severe cases, what happens is this actinomycosis can lead to an infection, almost like something called as actinomycosis. In this actinomycosis israeli, usually the portal of entry can be somewhere with a cavity, dental cavity can be present, or a trauma can be present, or a tooth extraction or some ulceration. So with this portal of entry, what happens is this israeli actinomycosis can lead to actinomycosis condition. The pathognomic feature of actinomycosis is it is usually a painless swelling, usually indurated painless swelling, which softens later, leading to abscess, and then multiple sinus openings can be present. However, it has a pathognomic feature where it usually appears as yellow sulfur granules within the pus. So naked eye, when we see the pus, it appears as yellow sulfur granules. Okay. These yellow sulfur granules actually, when crushed, when we crushed under a glass plate and we examine it under a microscope, we actually find two elements in it. One is mycelial, that is branching mycelial elements. Usually this is a gram-positive organism, gram-positive section of it. And usually these branching mycelial forms are the one which are excess in number, which are actually the predominant number is branching mycelia. Associated with it, we can see some amount of clubs. These clubs are usually gram-negative with a pear-shaped structures present. These are called as clubs. Normally, how we actually see this organism is the central granule will be present. From the central granule, these mycelia are usually radiating pattern. They actually have a radiating pattern. They are arranged in a radiating pattern around the sulfur granule, and surrounding it we see these clubs arranged. So when we actually see it appears like a sun ray, and hence it is also called as this actinomycosis israeli is also called as ray fungus. So these clubs which are present at the periphery of these radiating mycelia usually are known to act as a defensive mechanism from any other invading organism. So these are actually known to be defensive in mechanism. Now this is a picture where we can see actinomycosis within a gram stain, where we can see multiple mycelia present in the stain in the section. Now this actinomycosis species, when we are actually examining it, or when we are culturing it in the laboratory, on the broth it appears, on the nagar it appears as molar tooth shape, and in a broth medium it usually appears like a breadcrumb. Okay, these are two features that we actually see in a culture medium, even in agar or in a broth medium. Now, however, this actinomycosis is actually a anaerobic organism, which is a gram-positive one, and a filamentous in nature. This actinomycosis actually appears because of this mycelia. What happens is it is actually a bacteria, but because of this mycelia that is present, because of its appearance, it looks like a fungus, but it is a bacteria in nature. Okay. Now coming to clinical forms, this actinomycosis, we have three major clinical forms. With the most predominant one is facial-cervical actinomycosis. We also have pulmonary and genital and gastrointestinal actinomycosis. Okay, coming to facial-cervical actinomycosis. In this facial-cervical actinomycosis, the most common site is mandible, especially the posterior part of the mandible. It also called as lumpy jaw syndrome. Because of its appearance, it is also called as lumpy jaw syndrome. And the common site is mandible, especially in the posterior region. Normally, it appears like a firm swelling, firm mass or a swelling, which is usually painless. Sometimes what happens is this painless swelling, and underneath, it will actually get softened because it involves the whole of the bone. Actually, what happens is from the superficial portal of entry, either from a dental cavity or from an external trauma, this bacteria enters into it, and it causes necrosis of the region inside. What happens is the superficial structures, maybe the skin, underlying muscle, or the connective tissue, is completely destroyed, which is again replaced by granulation tissue. After this granulation tissue gets necrosed further, and underlying in the center they form an abscess condition. This abscess actually comes out with sinus opening, so it enters out with multiple sinus openings sometimes. Okay, so this is faciocervical actinomycosis. From this sinus opening, what happens is we see a thin pus kind of exudate. We see an exudate which is thin pus coming out with the characteristic sulfur granules within it. It's a pathognomic feature for actinomycosis again. And in this we have, now this is a picture which is showing complete actinomycosis which has been involving the mandible region there, where we can see multiple radiolucent, multiple moth-eaten appearance we can see here in this case of mandible. Now coming to abdominal form or gastrointestinal form of actinomycosis, most commonly in this abdominal form what happens is it involves your cecum or appendix. Okay, in the cecum or appendix is involved, and in this abdominal form of actinomycosis we have a characteristic flat grey nodules are present within the submucosa, and in this flat grey nodules, what happens is they turn into firm structures in a due course of time, and then they appear like a malignancies. Okay, so this abdominal form of actinomycosis must be differentiated with any malignancies that are usually occurring in the cecum or appendix. Normally what happens in actinomycosis condition is after in the due course of time, it actually causes suppuration within it, and it leads to multiple abscesses which again drain out. Usually in the abdominal wall is the one which is actually involved, where abdominal wall has multiple abscesses. The second most commonly involved organ is liver. In this liver also, in case of actinomycosis, what we see a honeycomb mass will be seen, where multiple abscesses are seen within the liver, and this liver with this multiple abscess, it actually appears like a sponge which has been saturated with the pus. Okay. So the characteristic feature in gastrointestinal form or abdominal form of actinomycosis is this: it is especially in the liver, it appears like a sponge which has been saturated with pus. Okay. Normally, what happens is in the liver, it is not by direct extension, but there is a blood-borne infection. Normally this actinomycosis need not spread usually by direct extension. However, if there is any lesion that is breaking the blood vessel wall, then from there it actually spreads into other visceral organs, internal organs. However, we do not have any lymphatic spread. It has not been noted where lymphatic spread of actinomycosis is seen. Okay, and the next one is genitourinary tract actinomycosis, where this genitourinary tract actinomycosis is usually seen especially in women who are using intrauterine devices. Okay, most commonly seen in women who use intrauterine devices. We can say this genitourinary tract actinomycosis. In this genitourinary tract actinomycosis, what happens is, if at all there are fistulas, it can actually complicate your abdominal actinomycosis. Then the third form, or again most common form, is we have pulmonary form or lung form, where it can be either direct extension from the upper, it can spread from your neck, cervicofacial one downwards, or from the abdominal upwards. This actinomycosis can involve the lung. It can be because of aspiration of fungus into the lungs. So pulmonary form of actinomycosis usually occur. Then it actually includes actinomycosis of pulmonary, bronchial region, and also laryngeal region. In case of this form of actinomycosis, here what we see is multiple abscesses which are present with it, multiple abscess cavities which are surrounded by abundant fibrous tissues. Okay, this is again the characteristic feature, and usually they are spread with the help of hematogenous route. Now, how do we actually diagnose them? First important thing is culture and the microscopic and macroscopic examination. Macroscopic examination, the yellow sulfur granules are pathognomic feature of actinomycosis, and in microscopic examination, we can see those two forms on staining, where the mycelial form and the club forms, which are again pathognomic for actinomycosis. We also have some other special stains other than your H&E staining, which will help us in diagnosing actinomycosis more firmly. These special stains include Grocott, Gomori, methenamide, silver nitrate stain. We have McCallin, good pasture stain, and we also have brown Brent stain, which are again special stains of actinomycosis. When we are coming to management of it, antibiotics are always useful in treating actinomycosis. Penicillin, we have lincomycin and tetracycline, which are other antibiotics which are commonly used in case of this actinomycosis. And as a rule says, whenever there is an abscess, drain it. So drainage of large abscesses will fasten the treatment procedure. In case of chronic sinus tracts, marsupialization will be helpful, where we actually excavate or we actually remove the sinus, whatever the sinus contents which are present within it. In those conditions, what we do is marsupialization of a chronic sinus tracts. And we have something called, in case of fibrotic lesions which are recalcitrant, which are reoccurring, in those cases excision is the best treatment. So debridement of necrotic bone tissue will also be helpful in fastening the treatment procedure, especially when we are using antibiotics. So this is about actinomycosis. Next we enter into another granulomatous disorder, which is nothing but leprosy. Leprosy is something like which has been age-old kind of disease, which we have, leprosy is been. We have notations about leprosy even in the Bible also. So leprosy is such an old disease, and when we're talking about it, the first thing that comes into is stigmata for leprotic people. Where especially the patients who are suffering from leprosy are face this stigma mostly because of the their deformities that we actually see on the fingers, etc. The body extreme parts, etc. In the case of leprosy, it is usually caused by Mycobacterium leprae or Lepromatous, Mycobacterium lepromatous, which is nothing but an acid-fast bacilli. Usually this Mycobacterium leprae has a very slow growth, very slow growth, and sometimes the incubation period can be 30 years also. So that itself shows us how slow this Mycobacterium leprae usually grow. And because of this slow growth, and also it doesn't involve the visceral organs or other vital structures, that is why it is not usually fatal. It is one of the most common cause of non-traumatic peripheral neuropathy, and leprosy is also called as Hansen's disease, as we all know. And this Hansen's disease has very much predilection for involving the peripheral nerves. Whenever the peripheral nerves are involved, and it causes thickening of these peripheral nerves and loss of sensation is seen in these cases. Hence, it is one of the most common cause of non-traumatic peripheral neuropathy across the world. When you're talking about this Mycobacterium leprae, which is an acid-fast bacilli, and this Mycobacterium leprae, lepromatosis is also present. Mycobacterium lepromatosis is also present, which is actually a newly identified organism. It is known to cause disseminated leprosy, which is actually very rare in condition. As we have seen, incubation period is usually, it can occur from few weeks to several years. It can extend up to 30 years also. When we're talking about various types of this leprosy, based on the clinical types, we actually have them into 5 types. One is tuberculoid type, borderline tuberculoid type, mid-borderline, lepromatous type, and borderline lepromatous type. Mid-borderline is something which is usually very rare in condition, and if this occurs, it is like a very severe form of leprosy again, but it is the very rarest of the cases. When we are talking about the parts involved, as we know, it involves skin and nerves. So based upon the number of skin lesions and based upon number of nerves involved, it can again classified. And for therapeutic purposes, this leprosy is being classified into paucibacillary and multibacillary. Paucibacillary, as the name itself indicates, it has less number of organisms in it. However, this paucibacillary, it has a particular feature where it is usually negative for smears at some regions, whereas in multibacillary, it is always positive at any one particular site. It is positive for the smears in case of multibacillary leprosy. We are talking about this lepromatous type. In lepromatous type of leprosy, what happens is the host response. Usually this clinical types are actually classified based upon the host response to this bacilli. In lepromatous type of leprosy, what happens is the host resistance is usually low and more amount of bacteria can be seen in these cases. Because the resistance is low, the immune reaction for this bacilli is less. Towards this bacilli is less. Hence, we see less number of polymorphonuclear leukocytes, less number of macrophages in this case of lepromatous leprosy. However, in lepromatous leprosy, what happens is the deformities are usually mild and late, but the disease is widespread. Lepromatous leprosy has a characteristic feature of leonine faces because it the saddle nose, the depression of your nasal bridge, and also the face itself takes a picture of a lion. Hence, it is called as leonine faces, characteristic feature of lepromatous leprosy. When you're talking about tuberculoid leprosy, here the host resistance or there is a strong tissue response towards it. Bacteria, the number of bacteria are usually less in case of tuberculoid leprosy cases. and it is usually localized, but early and severe form deformities can be seen in this tuberculoid leprosies. In borderline forms, the deformity is more severe when we're talking about tuberculoid leprosy. There is something called as pure neural leprosy. In this pure neural leprosy or neuromatous leprosy, what happens is only neural tissues are involved without any skin infection, without any skin lesions. That is, normally in leprosy what we see is hypopigmented macules are seen, but in this pure neural leprosy, you can only see leprosy that involve nerves. Now coming to clinical features. Pathognomic feature of this leprosy is three. First is hypopigmented macules. Second is involvement of peripheral nerves, where peripheral nerve thickening can be observed. And third is slit smear positive. That is, we can actually isolate the bacteria or bacilli from this region. So these three features are pathognomic features or diagnostic features for leprosy. So when we are talking about clinical features, what happens? We see multiple hypopigmented macules which are ill-defined borders, and usually at this region we actually have paresthesia of the skin. Normally the leprosy lesions involve cool areas, and warm areas such as axilla, groin are usually, or internal visceral organs are usually less commonly affected. That is the reason, as it is not involving those internal structures, it is usually not so potentially dangerous or not fatal in condition. Other important thing is, as we all think, leprosy is not due to direct contact. It usually spreads because of nasal discharge of the affected person. This is because the respiratory lining is been highly infected or severely infected in case of your tuberculosis, in case of your leprosy. The cellular infiltrates usually affect the nervous tissue, and this leads to thickening of the nervous tissue or stiffening of your nerves. The most common nerves that can be involved are superficial temporal nerve, your postauricular nerve is most commonly involved, ulnar nerve is also most commonly involved in case of leprosy. What happens is, these nerves get thickened, they become tender, and when you palpate it, they appear swollen and tender. Because of these conditions, what happens is, it usually responds less to your peripheral pricking. When we actually do the skin prick test, usually patient will have paresthesia or anesthesia in that region. And other important thing when we are talking about this nervous nervous tissue involvement is, usually when we see the patients with this leprosy, what happens most commonly, what we see is there are multiple deformities of the fingers. The fingers are usually deformed in these cases. One important thing is, these deformities are not direct effect of the disease or not a direct manifestation of a disease, but because of this peripheral nervous tissues are involved, what happens is they lose the pain sensation, and then they are mutilated in the process because there is no pain sensation. It can undergo trauma, there can be burning effect there can be burns in the skin, because patient is not responding immediately or there is no sudden reaction to any impulse in those cases. So because of this nervous tissue problems, what happens is there can be multiple deformities in these cases again. Next is, here in this picture what we see demarcated cutaneous lesions which are hypopigmented macules, again characteristic of leprosy. Normally these patients also will have impairment of vision, recent impairment of vision, and red painful eye is again another common feature of leprosy. And there will be, if there is any existing lag of thymus, it will be most worsened in, again it will further aggravate in those cases. We also see something called as trichiasis. Trichiasis is a condition where your eyelashes, there will be ingrowth or ingrowth of your eyelashes, that is reverse growing of eyelashes, and this will actually touch your conjunctiva. Instead of coming out like this, they actually grow inside, towards inside, touching the conjunctiva. That is nothing but trichiasis. We have epiphora, epistaxis in these conditions. We also have blockage or crusting of the nose and saddling of, and we also have this nasal bridge depression can be seen. Hoarseness of voice can also be seen in this case of leprosy. And another important feature is loss of sweating. Whenever there is affected macule or papule affected macule is present, in that particular region, patient will not have sweating. Which is again, when we are actually asking for history of or we are trying to diagnose the case, in the process of this history taking, we should ask the patient for loss of sweating in those regions, which is again a pathognomic feature for leprosy. And rhinitis is a condition, iridocyclitis, where nothing but iritis, where is inflammation of iris is present in those cases. Epididymitis can be seen, and this also can lead to severe deformities, especially on the extremities of the region. So this is a picture which is showing a leprosy deformities on the hands where fingers are completely mutilated in these cases. Now coming to diagnosis, how do we actually diagnose? Clinical examination. Clinical diagnosis will give us proper insight into leprosy. As we have seen the 3 pathognomic features, always remember hypopigmented macules, peripheral neuropathy associated with slit skin smear will actually help. Nerve sensation. How do we check for nerve sensation? Do a prick test. As you actually take a small prick and try to do this pricking on the nerves, and patient usually does not respond to your pricks. And slit skin smear, which will actually help us in identifying your bacteria there. You know, Lepromatous bacilli will be actually identified with the help of this slit skin smear test. Now coming to management of how do we actually manage dapsone. Dapsone is nothing but diamino diphenolsulfone is the drug of choice in case of treating leprosy, and here in dapsone is usually given about 50 to 100 milligrams daily. However, there are certain more amount of resistant cases are seen with this dapsone. It is because the treatment is usually a long-term course. If you are talking about lepromatous leprosy, it usually take about 10 years of time. When you are talking about tuberculoid leprosy, it usually take 3 years of time in treatment. Okay, as the treatment is so long-term, what happens is the compliance of the patient is sometimes lost. So patient stops taking the drug in between, and this will lead to resistance to dapsone. So to decrease this resistance to dapsone, what has been done is there is something called as multi-drug regimen therapy. So here, instead of using a single drug, we are using a combination of drugs. And the most commonly used combination of drugs are rifampicin, clofazimine and ethionamide. So when you are taking this combination of drugs, it is actually given in this following dosages. Like dapsone is given as 100 mg, clofazimine as 50 milligrams daily with supervised doses of rifampicin, which is 600 of milligrams, and clofazimine given 300 milligrams monthly for 2 years. So daily we give dapsone and clofazimine, and monthly what we give rifampicin and clofazimine. This will be given for about 2 years of time. Okay, this is nothing but your multi-drug therapy regimen. In cases where we want an alternative for clofazimine, we can use thiamine. One important thing is when you are actually giving this rifampicin, there is one particular side effect where you can see orangish, tears, sweat, urine is usually an adverse effect of this rifampicin. So when we are actually treating the patient, when patient is under rifampicin, warn the patient that this is actually an adverse effect of it. So it is normal because patient is actually on rifampicin. It actually tends to have this features in them. So this is orange urine or orange tears are usually seen in patients who are taking rifampicin. So this is about leprosy, types of leprosy, clinical types, and what are the various clinical features of these conditions and how we actually manage this leprosy. So this class is about actinomycosis and leprosy, and hope this had given you proper insight into these 2 topics. Thank you.